our next session, Lacrimal session. The chairperson of this session is Dr. Jan Kumar Das, sir. Right, he is not here. Might he engage in another hall? Co-chairperson Dr. Raviranjan, sir. Please take your seat. Co-convener Dr. Rajan Anand, sir. And moderator of this session is Dr. Sanjeev Kumar. इधर आ जाइए बस संजय बॉस इधर आ जाइए we have 10 presentation in this session and his presentation will be 5 minutes. First presenter is Dr. Ruchi. Dr. Ruchi is here. Yeah. He is a second year PG in Betia Medical College. आपका लोड है ना डॉक्टर रुचि?
Good afternoon, everyone.
This is the competitive session. So, Dr. Ruchi, please stick to your time. No, 5 minutes.
Good afternoon, everyone. I am Dr. Ruchi, and I am here to give my presentation on optical coherence tomography, imaging of proximal lacrimal system. I have no financial relationships to declare. The human lacrimal drainage system comprises an upper and lower punctum situated towards the medial end of eyelids. The lower punctum connects to a 2 mm section of descending vertical canaliculus before turning medially for 8 mm and join with the upper canaliculus, then into the lacrimal sac. Our aim was to study whether OCT may be used to image the punctum and proximal canaliculus. OCT image of the lower punctum were captured with a Topcon 3D OCT machine. Anterior segment module was used. Single line anterior high resolution scanning was used. 52 puncta of 28 subjects were scanned. The punctum was recognizable on the OCT image in all cases. The medial lower end was gently everted to expose the punctum to the OCT scanner with maximum care taken not to distort the anatomy. Canalicular length ranged from 462 to 1242 microns. Mean length was 864 micron. Peak width of canaliculum ranged from 126 to 401 micron with mean width of 234 micron. Punctal anatomy is clinically relevant in the management of epiphora because punctal stenosis is one of the major causes. It is also relevant to design the punctal plug and assessment of their function. However, there are currently no routinely used imaging modalities or objective quantitative assessment systems for the proximal lacrimal system. There is currently no other practical way to accurately image the punctum and the proximal canalicular morphology in vivo. OCT is a practical and readily available tool in most eye clinics. Its resolution is ideally suited to imaging of the punctum and proximal canaliculus. Punctal OCT relies on scanners' infrared beam traveling directly through the canaliculus rather than through the surrounding skin. Alignment of the punctum and the canaliculus with axis of scanner's infrared beam is essential. As the wall of the canaliculus often appear to come together in different shapes, it is difficult to decide which point to measure the diameter of the canaliculus. However, even the longest canaliculus that we imaged was still much shorter than 2 mm. This suggests that during resting period, maximum part of the proximal canalicular system may remain in collapsed state and it was not being picked up by ST-OCT. Probing with a syringe may similarly unreliable since it may cause dilation of the punctum and through not giving an accurate representation of the patient's normal anatomy. There are no routinely used imaging modalities for proximal lacrimal system. Development of an objective system for an imaging punctum is warranted. We can conclude that we have shown that OCT may be used to create a high-resolution image of the lacrimal punctum and canaliculus. Further work is required to establish its clinical applicability on wider scale. Thank you.
Second page, last one. B2287. Second page, last. Yeah. Any questions? Ranjeet, any questions? Thank you. Thank you, Rishi.
Thanks, sir.
Next presentation by Dr. Sandhya Yadav. Severe dry eye associated with the toxic epidermal necrolysis.
Good afternoon, everyone. Myself, Dr. Sandhya Yadav, final year postgraduate resident, GMCH Guwahati. I am here to present a case report on severe dry eye associated with toxic epidermal necrolysis. There is no financial disclosure. Introduction. Toxic epidermal necrolysis is a rare but severe mucocutaneous drug reaction affecting more than 30% body surface area with a high fatality rate. Severe cicatrizing ocular surface disease is one of the most significant and debilitating sequelae of Stevens-Johnson syndrome or toxic epidermal necrolysis. In emergency department, there was a 18-year-old girl who presented with painful generalized erythematous vesicobullous rashes with sloughing of skin, initially started from tongue, which then spread all over her body, including her genitals as well as oral cavity since 3 days. There was a history of fever, cough, anorexia since 3 days. She developed diminution of vision, both eye, which was associated with mucopurulent discharge, foreign body sensation, and redness since 2 days. There was no history of excessive watering, ocular pain, chronic history of topical ophthalmic medications, and use of contact lens. There was a history of generalized seizure for which patient was taking tab lamotrigine 50 mg twice daily since 15 days. And this was found to be the offending drug in this case, and patient was admitted under dermatology department where supportive treatment was done, and patient was started with IV steroids. This we can see for day 1, patient presented with sloughed eyelid skin with crusting and mucopurulent discharge. On bedside ocular examination, right eye visual acuity was hand movement close to face, while left eye it was normal at bedside. There was crusting of skin over the eyelid. 2/3 margin of the lid was involved in right eye, whereas 1/3 lid margin was involved for left eye. Both the puncta were plugged with discharge. Both the conjunctiva were hyperemic with mucopurulent discharge in the fornix with pseudomembrane formation. Cornea diffuse epithelial defect in interpalpebral area with intact corneal sensation in right eye, while there were few punctate epithelial defect in left eye. Rest was normal. This we can see on the first picture. There was hazy cornea with pseudomembrane formation. As per Gregory's grading, our case fall in severe ocular manifestation of 10, where there was more than 1/3 lid margin was involved. There was whole of the cornea of right side was involved, and conjunctiva there was stain positive more than 1 centimeter. Initially, medical management was done. Saline flush both eye with debridement of pseudomembrane using blunt tip cotton applicator was done. For medical management, moxifloxacin eye drop 0.5% was started for both eyes 6 times daily. Preservative-free tear substitute was used 1 hourly, and antibiotic steroid eye ointment was applied 4 times daily in both lid margin. But due to deteriorating general condition of the patient, amniotic membrane grafting was postponed and temporary BCL was done for right eye. On day 15, there was not much improvement noted for right eye, while left cornea was clear with persistent conjunctival injection. Surmer test 1 for right eye was 5 millimeter in 15 minutes, while for left eye it was 15 millimeter in 3 minutes. Amniotic membrane grafting was done for right eye to encourage the rapid epithelial healing and to reduce the inflammation and scarring in the ocular surface. This is amniotic membrane grafting for right eye, where we use dry amniotic membrane. It was sutured, covering whole of the cornea, conjunctiva, both the superior as well as inferior fornix and lid margin. On follow-up, patient right eye vision with aid, it was improved to 6.9, and for left eye it was 6.6. Schirmer test gradually improved from 10 millimeter in 5 minutes for right eye, while for left eye it was normal. Tear breakup time was 10 seconds for right eye, left eye was 15 seconds. Tear meniscus height was 0.5 millimeter, and there was clear cornea on fluorescein stain. Day 30, there was healed corneal epithelial defect. Day 45, there was reduction of inflammation and improved visual acuity. Discussion: in our case, patient presented with pseudomembranous conjunctivitis and corneal epithelial defect in acute stage and gradually developed severe dry eye in subacute stage. All patients with eyelid margin involvement, pseudomembrane and/or corneal and conjunctival epithelial defect should receive amniotic membrane within 4 to 7 days. Use of cryopreserved amniotic membrane can significantly reduce Deuce level 3 to Deuce level 1 and can also improve the tear breakup time. As seen in our case, visual acuity of the patient improved drastically. Conclusion: there are a number of windows of opportunity in the treatment of SJSO10 that, if passed up, lead to irreversible ocular damage with the accompanying discomfort and loss of vision. Thank you.
Thank you, Dr. Sandhya. Sir, any question? Ravinan sir? Rajan sir?
Why don't we use wet placental membrane?
So in our institute, like previously there were some cases reported in minor OT that there was infection post uses of that. So it was stopped. So that's why we have used cryopreserved amniotic membrane, which was available in market.
Next presentation with the Dr. Devraj ji. Topic of presentation is bacteriological study of chronic dacryocystitis in patient attending a tertiary eye hospital in Assam.
Good afternoon, one and all present here. Today I am going to present a study titled Bacteriological Study of Chronic Dacryocystitis in Patients Attending a Tertiary Hospital in Assam. No financial interest, authors have no conflict of interest. Ethical clearance and informed consent were taken before the start of the study. Introduction. Chronic dacryocystitis is a chronic inflammation of lacrimal sac and duct caused mainly secondary to nasolacrimal duct obstruction, infection from surrounding structures and trauma. Patients may present with watering, discharge or swelling over the lacrimal sac area. Materials and method. It is a cross-sectional study conducted in a tertiary care hospital in Assam for a period of 1 year. For the study, we took 70 patients with chronic dacryocystitis who have not used either systemic or topical antibiotic at least for the past 1 week, irrespective of sex, occupation, and economic status. So materials from lacrimal sac were collected in sterile swabs by Roplast test and by syringing, and were subjected to the following test. First, gram staining, culture, and for the culture we use blood agar, McConkey agar, nutrient agar, chocolate agar, and after inoculation the media plates were incubated aerobically at 37 degrees overnight in the incubator. If there were no growth of organisms on the plates after 24 hours, the plates were incubated for another 24 hours. Individual organisms were confirmed with biochemical tests. Antibiotic sensitive testing, it was done by standard disc diffusion method. Diameter of the zone of inhibition around the disc was measured, and if the zone was more than 15 millimeter in diameter, the organism was reported sensitive to the particular antibiotic. So from our study, we have observed that from the table number 1, we can see that out of 70 cases, 59 cases, that is 84.28% have bacterial growth, while 11 cases showed no growth. and out of which gram-positive cocci was the common predominant one, 54.28%, and gram-negative, 30%. Out of the gram-positive cocci, Staph aureus was the most common. This is the bar chart showing the findings. Table number 2, we can see from the antibiotic sensitivity test, the most sensitive antibiotic that we found was gefloxacin, which was 84.74%, followed by ciprofloxacin and gentamicin. Discussion, bacteriology of dacryocystitis. In a study, 84.28% of cases showed positive culture, while 15.71 showed no growth. Similar reports were also shown by other authors like D.V. Seal et al. In 1982, Bhuyan J. et al. In 2014, Sarkar I. et al. In 2015. And in our study, out of the gram-positive organism, the predominant pathogen was Staph aureus, followed by Strep pneumoniae and Staph epidermidis. And out of the negative bacilli, Pseudomonas was the predominant one, followed by E. coli, Klebsiella, and Acinetobacter baumannii. Similar reports were also shown by Mahajan V.M. et al. In 1983, Prakash R. et al. In 2012, Bhuyan J. et al. In 2014, Ragini Garg et al. In 2018, and 2020 by Metmo ESG et al. Antibiotic sensitivity. For antibiotic sensitivity testing, we subjected the isolates against commonly used antibiotics in the treatment of chronic dacryocystitis. The most sensitive antibiotic found was gefloxacin, which was 84.74%, followed by ciprofloxacin, 77.96%. Similar results were showing gefloxacin as the most sensitive antibiotic were reported by Bharati M. et al. In 2017, Nigam et al. In 2019, and Amrita Bajpai et al. In 2019, which was 84%. So coming to conclusion, chronic dacryocystitis is a common infection with high positive culture, which needs proper management. Sorry, sir.
Please conclude, you have excluded a time.
So before carrying out intraocular surgeries like cataract surgery to prevent dreaded complications like endophthalmitis, from our studies we found that Staph aureus was the most common pathogen, and gefloxacin was the most sensitive antibiotic against all pathogens isolated. These are my references. Thank you all.
Thank you, Dr. Devra. What was the inclusion criteria?
Sir, the inclusion criteria were patients with chronic dacryocystitis who have not used either systemic or topical antibiotics for the past 1 week, at least last 1 week, before coming to us.
What was the age of the patient?
Sir, age of the patients were the adult patients, not the pediatric age group, sir.
Mentioned in your study? Have you decided?
Sir, I have mentioned sorry, sir, I have included. In our studies, we have gotten only the adult patient, but the inclusion criteria was irrespective of age, sex, and gender.
Cross-sectional study.
Yes, sir.
How can you say this is a cross-sectional study?
So it was an OPD basis studies, whichever present to us, whatever patient we come across, we took the patient, sir.
Okay. What was the time frame?
So 1 year study.
Okay. Any question from our chairperson and chairperson? Okay. Thank you so much.
Thank you, sir.
Just one question to so what are the aim of that?
So the aim
Why
of
you
the
want-
study was
no,
to-
why we want a bacteriological study?
Sir, it is a common infection in our clinical practice with high positive culture. So before carrying out like intraocular surgeries, we need proper management. And for that proper management, we need to know the causative pathogens and the sensitivity pattern of the pathogens.
And if we know what it will help, what are the way we can help?
So we can give better treatment regime like the sensitive antibiotics.
Definitely. One. And
So
I am
further,
asking for one special.
surgical
thing.
management can also be done, sir.
No, surgery is almost, it is the same process.
Yes, yes,
Surgery
sir.
doesn't use issues. Surgery we are doing in a infectious way, we of course know, but why we want to know beforehand or at least at the time of,
To control the infection, sir.
yes, to control the infection, one, and second, yeah, that's I want to share with you as you're not a competitive session, you are not a member. So point is that if we know the organism
Yes, sir.
or sensitive pattern, then we can treat the patient, because one of the biggest problem with the cystorhinostomy, especially from external route, is the secondary infection.
Yes, sir.
Secondary infection is very, very dangerous, and it is very, very difficult to control. So we can treat the secondary hemorrhage, or we can prevent the secondary hemorrhage. For that, that sensitivity is very much essential.
Yes, sir.
But luckily, most of the time what happened, that organism was out during the time of operation, it is throat and nose, and maximum time that bacterial load is not too much. That's the reason we are little lucky. Otherwise, secondary hemorrhage is one of the big issues.
Yes, sir.
Thank you. Very
Yes,
good
sir.
paper.
Thank you, sir.
Dr. Devram, it was a nice presentation, but we cannot give you marks. Here, written here is you are not a non-ratified member, but well presented. Next presenter is Dr. Vijay Lavana. Dr. Vijay Lavana is here? No. Next to Dr. Arun Kumar. Dr. Arun Kumar. Dr. Meenakshi, please. नहीं absent है.
Good afternoon, everyone. My name is Dr. Meenakshi, and I'm going to present a case report of recurrent idiopathic orbital inflammatory disease. There are no financial disclosures about this presentation. First, I would like to give a brief introduction. It is a benign, non-infectious inflammation of the orbital structures without a known local or systemic cause. It's also known as non-specific orbital inflammation, orbital pseudotumor, or idiopathic inflammatory orbital disease. It's the third most common orbital disease seen in adults. It can be localized or diffuse. Commonly involves the orbital fat, lacrimal gland, as well as extraocular muscles. So a 35-year-old female patient presented to us with swelling in her left eye since 4 years. The swelling had always been in the left eye only and involved the upper part of the upper eyelid and sometimes even the whole upper lid. It was associated with pain and redness in the eye, and as per the patient, her vision was like never affected. The swelling subsided by the treatment but reoccurs after a few months of stopping treatment. She was a non-case of hypothyroidism and was on treatment and was well controlled by 25 microgram of thyroxine. And as per the old records available, she has taken some oral steroids for her condition. On examination, her visual acuity in both the eye was best corrected distance visual acuity was 6/6, and anterior segment of the right eye was within normal limit. This is her left eye. As you can see in the central picture, the left eye was swollen more on the outer portion of the eye and giving an S-shaped ptosis, and the temporal congestion, conjunctival congestion was also seen. The ocular movements, however, were free, painless, and full. The dilated fundus examination of both the eye was within normal limit. There was no disc edema or any other pathology appreciated. So we thought on lines of orbital cellulitis, so started her on some systemic antibiotics, amoxicillin and clavulanic acid, 625 mg TDS, along with some anti-inflammatory and painkillers, along with topical weak steroids and antibiotics. And in the meantime, we also ordered some systemic investigations for her. Her complete blood count with ESR count came out normal. Thyroid profile was well controlled. We also ordered a blood sugar and renal function test. Her old ultrasound B scan orbit, which was done like 1 month back, was within normal limit. Definitely there was swelling of soft tissue in the superolateral compartment of the orbit. However, there was no involvement of the ocular muscles mentioned.
Her MRI brain advice came out, showed some like non-specific demyelinating changes in the parietal region, and soft tissue thickening and inflammatory changes were seen involving the left superolateral aspect in extracorneal compartment in the region of lacrimal gland. The lacrimal gland was inseparable from the swelling, and the swelling extended to left preseptal region and shows loss of fat plane with adjacent part of left lateral rectus. Bilateral extraocular muscles were normal in size and signal intensity. So we were confused because the whole these pictures were pointing towards the pseudotumor, but still because the patient had a history of 4 years, and again she was complaining that as soon as she stops the treatment, the swelling comes back. So we couldn't rule out the lymphoproliferative disorder. So we ordered a FNAC for her, which shows non-specific polymorphic nuclear cells suggestive of inflammatory pathology. No abnormal malignant cells were seen. So we started her on oral steroids 40 milligram, and along with the PPI and along the topical treatment we started kept continued. This is her eye 4 weeks after the treatment. The swelling completely reduced. The conjunctival congestion was gone, and she was feeling much better symptomatically. Coming on to the discussion part. So inflammatory orbital eye disease is not like a rare disease. It's very common, and the commonest presentation of this disease is abrupt painful swelling of the lid or lacrimal gland area, and patient can even have proptosis. Mainly it's unilateral, but bilateral cases are seen in pediatric patients. So for such patients, basically why I'm presenting this is case to point out the important things that should be done while examination. Like you should always examine the lid, because sometimes the main differential diagnosis of this disease is thyroid eye disease, which can lead to certain restricted movements. We should always check the ocular movements, because thyroid and this disease both can involve extraocular muscles. We should always dilate the patient, because as the name suggests, it's an inflammatory eye disease. It can even sometimes lead to optic disc edema. So the various differentials of this disease is orbital cellulitis, thyroid eye disease, sarcoidosis, and lymphoproliferative disease. Thank you.
Thank you, Dr. Meenakshi.
Thank you, sir.
How can you differentiate between the Tolosa-Hunt syndrome and pseudotumor? Because it is recurrent in nature. What was the cause of recurrence?
Probably we suspected that she didn't take her treatment with full compliance. I really doubt about her compliance. That's why maybe she was having this recurrence, because we didn't suspect it Tolosa-Hunt, because systemically Tolosa-Hunt that would be more severe symptomatically patient will present as compared to inflammatory orbital eye disease. That's why.
Have you taken a FNSC? FNSC or tissue biopsy?
We did sir FNAC actually. We advised FNAC, and she came out with the report to us.
What are that's why Professor Gyan wants to know, what are the disadvantages of FNAC?
So to rule out any lymphoproliferative.
No, disadvantage of FNAC.
Because
In compared to the incisional biopsy, or what are the disadvantages? FNAC.
Because patient is young and recurrent in nature, so FNSC, we should do the tissue biopsy at least to confirm the.
Not FNAC actually. That's
Okay,
why.
sir. Okay, sir.
In future, you can try for a tissue biopsy. That is the incisional biopsy.
Surely,
one.
sir. Surely.
Second is that in your slide, you mention use MRI brain.
Yes, sir.
Your lesson was clearly in orbit. Why you advise MRI brain? What is the reason, and what is your justification? It is a very difficult, so there is a tendency of lots of doctors to write a MRI brain and orbit. It is a huge cost. Cost-wise, in abroad it is very high. That's why be careful for any investigation. Either you can go for a MRI brain and orbit, so in such cases you can save lots of money. Moment you can write brain and MRI separately is a huge cost, one. Second is that in orbital thing, we can tell up to orbital apex. Moment, if you want to see something also, if you mention orbital apex, then it will serve the purpose. So most of the part of the brain will be picked it up in this is a technical point. So in your practice, if you can write to your radiologist up to the orbital apex, so it will be over. Like in, suppose in dermoid, if you want to see, is there anything is intracranial extension, then if you write CT brain or MRI brain is enough. Because if there is a nothing connected, so it is a orbital. To save down. Okay, thank you.
Noted. Thank you so much, sir.
Next presentation by Dr. Sanjeev Kumar. Sanjeev sir. Dr. Sanjeev sir, professor in Patna Medical College. Presentation the solitary fibrous tumor of the lacrimal sac, a rare case report.
Very good afternoon to all of you. Solitary fibrous tumor of the lacrimal sac, a very rare case report. SFT is a spindle cell neoplasm of mesenchymal fibroblast cell, and this tumor has been reported in numerous other locations, but the most common sites are fluor and peritoneum. Worldwide, only few cases have been reported. So only 2 from the India, and total of 8 cases have been reported worldwide. Solitary fibrous tumor of the orbit may be typically present as benign orbital mass, and it may present as unilateral, painless, slowly proptosis of the or a palpable mass in the periocular area. A 34-year-old young female presented to our OPD with the complaint of excessive lacrimation from the left eye since 3 years, and there is slowly growing mass. Past history, treatment history, and medical history not very significant. On ocular examination, best corrected visual acuity in the right eye 6/6, anti-segment within normal limits. In the left eye, best corrected visual acuity was 6/6, and location of mass was below the medial canthal tendon, and it's mimicking a lacrimal sac mucocell. Size was 1.5 centimeter and 1 centimeter. Surface was smooth, consistency firm, and there was no discharge noted on pressing over the lacrimal sac, so Rupplas negative. But on pressure syringing, there was flow. So it was suggestive of the partial NLD obstruction. So we decided, actually there was, tumor was the firm inconsistency, so we decided to do the contrast enhanced CT scan of the orbit and pharyngeal sinuses, and there was a well circumscribed approximately 2 centimeter and 1.5 centimeter and 1.8 centimeter enhancing lesion that is centered at the lacrimal fossa, which is extending along the medial orbital wall. There is no internal calcification or any cystic changes. And so complete surgical removal of the mass by cystectomy was done. On gross pathological examination, a well circumscribed brownish red mass with high vascularity of the tumor and measuring such and such, having firm consistency was found. On cut section, the mass shows a solid brown surface with area of hemorrhage. On histopathological examination, there was islands of fibrous tissue proliferation and collagen material, and then on higher magnification, there was prominent vasculature with pericytomatous arrangement of tumor cells without a cellular atypia, and it was a Stackhorn pattern. So next, immunohistochemistry was planned, and there was strongly CD34 positive cells was found, and BCL2 was also positive. Coming to the discussion part, SFT, it has a common histopathological morphology with hemangiopericytoma, giant cell angiofibroma, and fibrous histiocytoma. So one school of thought is to classify all these tumors together under the general term SFT. And these are characterized by haphazardly arranged fibroblast-like cells, and distinct nuclei, prominent vasculature with perivascular fibrosis and variable stromal collagen. The differentiating point in the, there is diffuse, strong immunochemical staining with the CD34 cells. So there is strongly positive CD34 cells, whereas in other conditions, there was weak and patchy CD34 staining. Due to its rarity and variability in presentation, there is high chance of misdiagnosis. Hence, comprehensive ophthalmological examination, including radiological, histological, and immediate immunohistochemical investigation should be done to clinch the diagnosis. as there is high chance of recurrence, so complete surgical excision and continued follow-up should be emphasized. Now coming to the, I followed this patient for up to 6 months, so, and there was no recurrence at all. Thank you.
Thank you, Dr. Sanjeev. Any comments or question for our chairperson?
So it's a what investigation done?
Sir, actually, sir, what happened, sir? The lady came to us with the complaint of registration and buttering. So we thought that usually mucocele is there, but there was firm inconsistency. So we thought that we counseled the patient and we advised her to go to Contagion CT scan, and that came out to be a solid tumor. So we planned for the ductal cystectomy. We sent that tissue for histopathological examination, and they told that this is a very rare tumor, and at that time there was no report from India, sir. Only 2 cases have been reported from India, one from us and one from Sangha Natalia. And worldwide only 6 cases have been reported. So one doctor from LVPI, he told me that do the immunohistochemistry. So I sent the patient at BHU and there he did, and that came out to be a selective fibrous tumor with lacrimal sac.
Fine, fine.
So
Now,
that
we
was the case,
want
sir.
to know, because it's a rare presentation.
Yes.
So on which level, at what level you detect it as a tumor?
Sir, because during palpation, sir, there was consistency was firm, sir. You know, sir, mucocele, it is soft.
No,
It is firm.
it was a preoperatively it was detected.
Pre-operative, sir,
Yes.
during the CT scan examination, sir.
Very good, very good. That's why it is a take-home message, very excellent. So if the Doppler is negative and it is in a suspicion, our in mind should be in suspicious.
Yes,
That's
sir.
why it was, sometimes if we do a DCT and we can, in Western country, if we do any surgery, any excision, and there is a rule of the thumb, we should go for a histopathological examination. That's why that it is less reported. Maybe we miss earlier lots.
Yes, yes, sir.
So if the very big in consistency, but Doppler is negative, then we can suspect. I have one publication, not in like this tumor, it was a worm. It
Actually,
was a worm.
Everybody was thinking that this is
Yes.
mucocele, so we should do the
Yes, yes.
dactylocytostomy, and
Very
but
good, very
at that time, and one interesting part is that, sir, I got the second patient also for inconsistency. I counseled the patient, but
Yes.
he was not agree, poor patient, and I told him that we will help you, but he didn't agree. So that
Definitely,
was the thing,
definitely,
sir.
those are the
Sometimes
issue.
we got some interesting cases.
In such cases, you can do whatever. You can write to some government hospitals like a BSU, whichever nearest to you, or you can send to the government hospitals. Even in private hospital also, they will. If you have any such cases, then you can write to me also. I have some lab, tie up with
Yes.
some lab, and they are very much interested for those type of work.
And for investigation parts, sir, we have spent from our pocket 5,000 rupees, sir.
Yes, very good thing is that very good, and as you detect in early, most of the time, if another option is that for that young, the doctors I am telling, if you suspect, make it open up also. Sometimes there may be the tissue consistency is not looks like your chronic decrecitus or mucocele type of thing. That you can just immediately do the DCT. If you are planned for DCR also, in such cases there is no harm. You can go for DCT and send for histopathological examination. Very good, sir.
Thank you, sir.
Excellent.
Thank you so much.
Thank you so much, sir. Next presentation will be by Dr. Raviranjan, sir. He is one of the popular and famous lacrosse BCR surgeon, sir. The presentation of bumpy roads to fail DCR made smooth.
वहाँ तो हमने वो कराया था, इसको लोड कराया था।
हो जाता है। तुमने हम लोगों को 20 मिनट लेट दिए हो, तब 20 और 5 25 जोड़ लो, ठीक ना? हो जाएगा, टेंशन नहीं लो। हो जाएगा, हो जाएगा।
साइज है क्या सर, इसीलिए थोड़ा टाइम
इसको
लगेगा।
ओपन करो।
कौन सी सर?
शिवाली राज हैं? ठीक है।
ये वाली।
And Dr. Meghna.
Dr. Meghna is okay.
So two more
Please
speakers.
come forward.
Two more speakers left.
Very good afternoon, everyone. My topic for today is bumpy roads to fail DCR made smooth. No financial relationship to decay. As published in various journals, success rate of external DCR is 85 to 97%. In spite of excellent success rate, there are a large number of cases with failure, typically due to these uh, these causes. The aim of this study is to assess the success rate of repeat DCR by a small changes in surgical steps. And this is a prospective, uncontrolled, and interventional study consisting of 134 patients of failed DCR. From March 2011 to March 2021, all the surgeries done by single surgeons to minimize the outcome bias of the surgical experience. And persistence of epiphora with a regurgitation of pus or tear in pressing lacrimal sac area after at least 6 months of primary procedure was the inclusion criteria for this study. And the incision were made on the previous surgical scar and intervening fibrous tissue were excised. And roughly 1 to 2 mm of the lacrimal sac around common canaliculi was shaved because it is always difficult to get sufficient flaps for mucosal anastomosis in repeat surgeries, so that the sac remains as a disc with a punctum in its middle, similar to a funnel. And 10 mm Aruga's bone trephine was used here to make osteum in nasal bone and nasal mucosa, and the remaining anterior part of the sac was sutured with the subcutaneous tissue and periosteum at the medial side. And the skin was opposed, and on the 5th post-operative day, syringing of 1 ml of 0.4 milligram per ml of mitomycin is syringed in newly formed passes, and these all cases were followed up for 1 year, and this is the nasal endoscopy after 1 year. And here you can say clearly nasal osteum. All the cases were followed up on 5th day, 1 month, 3 months, 6 months, and 1 year post-operatively. And each visit, the surgical outcome was assessed anatomically and functionally based on the records from the last visit. And the result of 134 patients over 10 years, that is the 131 patients were successful at the end of mean follow-up period, that is 12 months, and 2 patients complained of epiphora of grade 2 or more, and sticky eye despite successful syringing and patent newly formed passes, maybe due to physiological causes. And 1 patient failed in syringing. That's our anatomical success rate in repeat DCR is 99.2%, and functional success rate is 97.7%. And the further comparison of this study with previously published studies, meta-analysis were performed using MedCalc software, and this is the comparison of the success rate with published studies with mine study. This is forest plot depict the study of Wu et al. Pointer. Can be source of heterogeneity, and on meta-analysis of success rate showing significant heterogeneity, and the p-value for my study is less than 0.0001 that is very much significant. And this is funnel plot and symmetrical plot suggest absence of bias, and we conceptualize this method to overcome the problem and make the repeat DCR surgery easy to perform with successful result with a short learning curve. And changes we made are use of Aruga's bone trephine, approximately 1 mm to 2 mm the lacrimal sac was shaved around the common internal opening. And 1 ml of 0.4 milligram per ml mitomycin syringing in newly formed passes on the 5th post-operative day. And we use 0.4 milligram mitomycin C because on the safest and most effective dose of mitomycin C is somewhere between 0.2 milligram per ml to 0.4 milligram per ml. And we used 1 ml of 0.4 milligram per ml mitomycin syringing on 5th post-operative day, so that the anti-fibrotic property of mitomycin is utilized maximally, as it is not diluted by bleeding from nasal mucosa, and better coincides to early proliferative phase of wound healing, which starts from 4 to 5 days of tissue injury. And thus, in conclusion, I can say this method is easy to perform with reliable and comparative results, and its no costly instruments, can be used for mass surgery is kept as its anatomical success rate. My anatomical success rate is 99.2% and confidence, CI 95% is 95.9 to 99.9%. So yeah, I can say this is not for them, but it is a boon for the masses because it is easy to do with a less expensive method. Thank you, and I'm thankful to Javed Ali from LBPI, and Dhiren, my friend, ENT surgeon, and my aesthetician Lokesh. Thank you, and these are the references.
Thank you, sir. Sir, I have one question, sir. What was your inclusion criteria? You have did this type of surgery only in NLDO or CCB cases, common canalicular obstruction cases?
क्या क्या फिर
सर ये खाली नेजो लैक्रिमल डक्ट ऑब्स्ट्रक्शन के में है या फिर सीसीबी कॉमन कैनुकुलर के लिए भी इंडिकेटेड है?
नहीं लेजो रेक्लामर डक्ट ऑब्स्ट्रक्शन में
तो
कैनालिकुलाई ऑब्स्ट्रक्शन में नहीं हो.
Yes, sir. What are the most common cause of failure, sir, in your cases?
Improper method. If you can make an ostium on improper place, that is the most common method, common cause of failure, in my cases at least.
Okay, sir. Any question from our chairperson, sir?
It was improper. Improper means it was superior, inferior, or inadequate.
It may be, sir, inadequate because most of the time we get very small ostium.
Yes.
Or on just upper to the proper place, what should be.
You started all those for a second sitting after how many months of failure?
After 6 months.
After 6 months.
That is written in the slides.
Okay, so that I think it will be little difficult technically because the size, it may be inadequate location, but size generally reduces significantly after 6 months. To 1.5, it may be 1.5 even.
I have done many cases endoscopy too. I do usually endoscopy, and at least after 4 months, if it is fixed, it will go on. Maximum shrinkage on 3 to 4 months.
Yes, yes. Maximum shrinkage on 3 to 4 months, agree. But that's why that in my some cases or in books says there is a generally location and scar. Those are the two factors for failure. There is
In my view, scarring is not a cause. I mean, improper
location. And
ostium.
Thank you.
Thank you, sir.
Thank you.
Next presentation will be by Dr. Shivali Raj. Comparative study between the DCR with bicanalicular intubation and DCR using mitomycin C.
Good afternoon, all dignitaries and judges. I'm here to present my topic, comparative study between decliocystocystostomy with bicanalicular intubation and decliocystocystomy using mitomycin C.
Slide show में कर दीजिए.
No financial interest. So decliocystocystomy is surgical procedure to create drainage between lacrimal sac and nasal cavity via bony ostium. And external DCR is considered gold standard with success rate of 90%, while 10% cases still fail. Various adjuncts like canalicular intubation, mitomycin C, and implants are nowadays being used to further increase the success rate. So aim of our study is to prospectively and comparatively explore the efficacy of bicanalicular intubation in DCR over DCR using mitomycin C in preventing recurrence and compare the surgical outcome. It was prospective study done for 2 years in 28 patients presenting to OPD with symptom of NLD obstruction and chronic decliocystitis. Of 28, 22 female and 6 male that were randomly divided in group of 14 each. In group 1, 14 patients underwent DCR with bicanalicular silicon tube intubation, and in group 2, we performed DCR using intraoperative mitomycin C, that of 0.2 mg per ml concentration. We included 20 to 60 year age age group patient and NLD obstruction and chronic dacryocystitis. However, patient with acute dacryocystitis, nasal pathology, any canalicular obstruction or previous duct surgery were excluded, and preoperative evaluation for the local, ocular, and systemic examination, and also the ENT evaluation was performed in all the cases, and surgeries were done under local anesthesia. Curvilinear skin incision of 10 to 12 mm was given along the anterior lacrimal crest, and we performed 12 mm to 12 mm osteotomy site. In group 1, bicanalicular silicone tube intubation was done through upper and lower puncta, and drainage tube was tied internally by external nails by 5-0-ethylone. In group 2, intraoperative mitomycin C 0.2 mg was applied through mitomycin C soaked cotton sponge over the osteotomy site under the surface of lacrimal and mucosal flap 1 by 1 for 4 minutes, and postoperative antibiotics given, nasal packing done, and we removed it after 24 hours. We followed the patient at first week, 3 month, first month and 6 month, and intubation tube was removed at 4 week, and the patency of NLD was confirmed by syringing. We used SSP software and chi-square test. So the picture showing patient undergoing bicanalicular intubation DCR. In results, in group 1 DCR with bicanalicular intubation, 92.9, that is 13 out of 14 patients showed the successful DCR with reference to relief from EP4A and successful syringing at end of 6 months. In group 2, DCR with intraoperative mitomycin C, 85.7, that is 12 out of 14 patient DCR was successful and 2 cases failed with persistent EP4A, and the p-value was 0.541, which is not statistically significant. In our study, maximum incidence was found in 31 to 40 year age group, that is 42%, 78% were female. Both group had the female preponderance. That can be due to narrow lumen of lacrimal bone, NLD, hormone, and also the osteoporotic changes in post-menopausal women. Success rate obviously more in bicanalicular intubation. We assess the criteria based on EP4 and successful syringing at end of 6 months, and the commonest cause of DCR failure that we encountered was obstruction and common canaliculus and osteotomy site closure. That is well solved by the silicone tube that prevents the blockage of osteum, allows the epithelial tract to form around the tube, or also the anti-proliferative agent mitomycin C that is suppressing the fibrosis and scarring. So, limitation of our study is small sample size and duration is short. Finding our study suggests that DCR with bicanalicular intubation yield more success rate than the DCR with mitomycin C, though DCR with mitomycin C is cost effective and time effective, but bicanalicular intubation can add the beneficial effect in canalicular obstruction, puncture problem, osteotomy site closure, and preventing the recurrence. Thus, DCR with bicanalicular intubation can be good choice of surgery in the NLDO cases. So references, and thank you so much.
Thank you, Dr. Shivali.
Yes, sir. We compared our study with previous results. However, the DCR success is always varying in various studies. In some studies by Dr. Javed Ali sir, he tells about the going up to the 95% and even 98% success rate is achieved. However, as far as is the bicanalicular intubation and mitomycin C comparative study, the two adjuncts are not that much studied in the various study. The particularized study of the DCR and the bicanalicular intubations are there, in which the results vary, and they suggest that the cases are varying according to surgeons. Some believe that it is more for the failure cases, and some the canalicular obstruction and DCR is better. So the study somewhere lies in between the debatable answer, and so we pick up this study to compare the bicanalicular intubation and mitomycin C.
In your case, what was the indication for MMC or silastic intubation?
Sir?
Indication for silastic intubation or MMC? In all cases randomly, or you did in some selected cases?
Sir, we selected the primary cases of the chronic dacryocystitis and NLD, and then we randomly divided it in the two groups, and for one group we performed the bicanalicular intubation, and one we performed the mitomycin.
That's the answer is there. So generally, there may be some amount of problems with silastic intubation, like
Yes,
in granuloma formation, there may be a lost, sometimes very rarely, and sometimes in case of a pediatric and some very careless patient, they may pull it, there may be injury in the mucosa. If in a clear-cut case, generally, intubation is not required in maximum surgeons nowadays feel that with or without intubation the same results. That's your cases. The criteria should be
Sir,
very. That's the reason
thank you,
is
sir.
not so
Thank you,
much.
sir.
Yeah.
So we excluded the extreme age of the patient and we kept it in the safer side for 20 to 60 years.
Okay.
Thank you, sir.
Okay. Fine.
Thank you, sir.
Thank you, Dr. Swali. Next presentation by Dr. Meghna.
Good afternoon, everyone. I'm Dr. Meghna. My paper topic is histopathological study of lacrimal sac in cases of chronic dactylcystitis. As already described, diseases of lacrimal drainage system account for nearly 3% of visits to eye clinic, and among them, chronic dactylcystitis is the most common one. It can be acute or chronic. Chronic is more common than the acute form, and it is usually associated with obstruction of nasolacrimal duct. It may be idiopathic or secondary to various infections, inflammations, or injuries, or even neoplasms. The aim of my study is to evaluate the histopathology of specimens obtained after DCT and to score the chronic inflammation. My study design is a prospective observational study. It is done in about 10 patients in a period of 2 months at Sarojini Devi Eye Hospital. My inclusion criteria is patients with chronic dactylcystitis of all ages and both genders. Exclusion criteria are recurrent cases with previous history of DCT done. The procedure, a thorough preoperative ophthalmic checkup was undertaken for all the patients to rule out any other abnormalities. Then the lacrimal drainage system was assessed by means of syringing and probing to confirm nasolacrimal duct obstruction. Then DCT was done and the specimens of lacrimal sac were collected and sent for histopathological examination in 10% neutral buffered formalin. There the slides were examined. They're appropriately processed for paraffin blocks and stained with H&D stain. They were examined for the chronic inflammatory cell infiltration, fibrosis, and capillary proliferation, and whenever present, they were graded according to severity. This gradation was done using the same scheme as AMIN-RM. So here we will be dividing it into mild, moderate, and severe, and each entity, inflammatory cell infiltrate, fibrosis, and capillary proliferation, they're graded according to the number of cells or the percentage of fibrosis or the number of capillaries we see per one high power field. And then a chronic inflammation score ranging between 3 and 9 was recorded for each case after adding the individual scores for each of these histopathologic features. This final score was used to categorize each case as mild, moderate, and severe. The results, age distribution in the study population, majority of my patients belong to 50 to 60 years age group, and gender distribution, majority of the patients were females. The patients, about 50% of the patients came with the signs of mucopurulent discharge, and 40% of the patients with epiphora with clear fluid, and then one patient we got with the mucocele. These are the sections showing epithelium lined by pseudostratified columnar epithelium with goblet cells, and subepithelium showing lymphocytes and plasma cells infiltration and some destroyed capillaries. Very few slides have fibrosis in our cases. These are my histopathologic findings which will be discussed. Chronic inflammatory cell infiltration was found to be mild in 2 cases, moderate in 5, and severe in 3 cases. Only mild fibrosis was observed in half of the collected specimens. Severe grade of capillary proliferation was found in 2 cases. Diffuse chronic inflammation with marked vascular proliferation was noted in some of those cases. So basically the chronic inflammation score was calculated in each case, and it revealed that 30% cases belong to the mild group, 50% to the moderate group, and 20% to the severe category. Chronic dactylcystitis is mostly associated with non-specific chronic inflammation. Specific pathologies, both inflammatory and neoplastic, have been reported in 0 to 14.3% cases in previous studies. But our study has a very limited number of cases and done under a relatively shorter time period. So incidence of neoplastic changes or granulomatous changes was not seen. Anderson et al. And other studies highlighted that even though most lacrimal sac biopsies reveal non-specific chronic inflammation, routine biopsies must always be undertaken to rule out any specific pathologies and also for understanding of various diseases of lacrimal system. To conclude, we recommend that chronic inflammation score must be included in the histological evaluation of specimens obtained by DCT. Since greater degree of inflammation is associated with a poor and delayed rehabilitation post-surgery, this score would help clinicians to monitor the dose and duration of therapy with NSAIDs. Also, malignant or systemic disease in patients with neither specific history nor clinical or radiological findings might be observed, so it is better to take a histopathological examination also. Thus, we recommend taking biopsy if any suspicion is there. These are my references. Thank you.
Thank you, Dr. Meghna. One question, have we compared any change in the histopathology with the age?
No, sir, I haven't compared. I should have. We haven't compared with age. I should.
Any question from chairperson, sir?
Exclude the tumor, and in next study you can tell your histopathologist to grade
Yes, sir.
the grade of what are the grades of inflammation, what are the things, infiltration, etc. So we can tell, and you can support him all is a Roplus positive or negative, clear fluid or what, purulent, and you can compare with the organism also.
Yes, sir.
The inflammatory pattern depends along the organism. Suppose if organism is very virulent and it is like a pseudomonas, etc. In such cases, always you can compare with your organism.
Yes.
You can support the organism that ideally it should be along the culture sensitivity pattern.
Yes.
We can compare, then there will be more results.
Yes, sir.
Here only you can say it is a tumor or not tumor.
Actually, my research was cut short because our septic OT got closer, but I'm still continuing after the renovation. Then I would definitely do this correlation with micro.
Not along with as your other one word septic OT.
Yeah.
None of the OT is septic.
We.
If it is a minor OT and septic OT, it should be eliminated from our mind. All OTs, even if we do a culture, sometimes there is a cataract, there is an organism. But I am working in both OTs, cataract as well as in the DCR OTs or other OTs. But in surprisingly, in DCR OTs, there has been the basic level of organisms. So there is none of the OT is septic. This is our misconception. Okay. Please request everyone. So DCR is not done in a septic OT. It is in a number of the OT. It may be one number or two number or three number. None it is a minority, nor it is a septic OT.
Okay, sir. Thank you.
Okay, thank you everyone. May I request our chairperson and panelist and also the speaker to come here for the one photograph.